Type of the manuscript, original article. Title, Association between ANA profile and different SLE manifestations. Running title, ANA profile and SLE manifestations. Authors, Isam M. Abulfadl, MD, Assistant Professor of Rheumatology, Sohag University, abulfadl71@yahoo.com. Ahmed R. Radwan, Assistant Professor of Rheumatology, Sohag University, Ahmed_Radwan at med.sohag.edu.eg. Abdullah H. K. Ali, Assistant Professor of Respiratory Medicine, Sohag University, abdullahdiab at outlook.com. Mahmoud G. Mahmoud, Lecturer of Internal Medicine, Sohag University, Mamajaber at med.sohag.edu.eg. Ahmed N. Neraldin, Lecturer of Internal Medicine, Sohag University, Ahmednagar 3000 at yahoo.com. Amal H. Ali, Lecturer of Medical Microbiology and Immunology, Aswan University, Dramal Salama 2018 at yahoo.com. Hesham M. Hefni, Lecturer of Clinical Pathology, Sohag University, h.hefni1974 at gmail.com. Manuscript numerical data. Total number of pages. Total number of photographs/figures. Word count. Abstract, 199. Text, 3,563. Introduction plus discussion, 1100. Source of support, not applicable. Acknowledgement, not applicable. Presented as part in meeting, no. Conflict of interest, not applicable. The corresponding author stated that the manuscript has been read and approved by all the authors. Corresponding author, Ahmed Rashdi Alagami Radwan, Assistant Professor of Rheumatology, Sohag University, Nile Street, Nasir City, Sohag, zip code 52824, Egypt. Telephone, +20 109 291 4019, +20 111 523 0730. Email, Ahmed_Radwan at med.sohag.edu.eg. Declarations and conflict of interests. Ethics approval. The research was approved for application from the local ethical committee of Sohag University Hospital. Consent to participate. All included cases signed an informed written consent after detailed explanation of the research nature. Availability of data and material. Data of the current study are available with the corresponding author, but patients' personal data would not be given to a third party. Competing interests. The authors declare that there are no competing interests. Funding. The authors did not receive any funding from any governmental or private sources. All authors have read and approved the manuscript. Abstract. Background. SLE is considered a classic model of the immune complex-mediated disease. The occurrence of antinuclear antibodies, ANA, in serum is a common finding. The multiplicity of ANAs made it difficult to associate each individual antibody with different manifestations of SLE. This study aimed to evaluate the relationship between different ANAs detected by ANA immunoassay and different clinical and laboratory characteristics of SLE patients in Upper Egypt. Methods and findings. A descriptive cross-sectional study included SLE cases diagnosed according to the 2019 ACR/Schiller classification criteria. They were subjected to complete history taking, full general and systematic examination, CBC, up/C ratio, C3 and C4, ANA, by indirect immunofluorescence assay, IIF, and specific antinuclear antibodies by DOT immunoassay. We found that the most common clinical manifestation was fever, followed by arthralgia, then acute cutaneous lupus, alopecia, proteinuria, arthritis, and oral ulcers. The most common pattern seen was speckled, followed by the homogeneous pattern. The ANA immunoassay showed that the most common ANA found was anti-Rho 60, followed by anti-dsDNA, then anti-Rho 52. Conclusion. The ANA.immunoassay is essential for the diagnosis, prediction, and assessment of internal organ involvement and for follow-up and prognosis of SLE cases. Keywords: ANA, ANA profile, SLE, immunoassay. Introduction. Systemic lupus erythematosus, SLE, the prototype of systemic autoimmune disorders, has been considered for many years a classic model of the immune complex-mediated disease. However, earlier data demonstrate that multilevel dysfunction of cellular and humoral immunity underlie the pathophysiology of the disorder. 1. The spectrum of clinical manifestations of SLE is remarkably variable with an unpredictable disease course. It is characterized by episodes of exacerbations and remissions. Disease flares with cumulative damage with time can largely interfere with the quality of life and can lead to marked morbidity and higher mortality rates. 2. Despite the considerable differences between patients with SLE, the detection of antinuclear antibodies, ANA, in the serum at the time of diagnosis is a common finding with very few exceptions. 3. Different methods of ANA detection were described, with the immunofluorescence, if, is considered as the gold standard technique by far, 4 to 6. An abnormal titer of ANA assessed by immunofluorescence, if, microscopy, IFANA, is one of the 11 criteria for SLE according to the 1982 American College of Rheumatology, ACR 82, validated classification criteria. 7. The 1997 revised criteria. 8. And the Systemic Lupus International Collaborating Clinics, SLIC, criteria state that an ANA test, 9. All of these criteria did not specify a cutoff level of ANAIF. The new 2019 ACR/Schiller criteria for the classification of SLE was the first to determine a cutoff of ANAIF as 1/80th or more as an entry criterion for SLE classification, which means that cases with negative ANAIF or with lower titer would not be suitable for inclusion in these criteria from the start. 10. Antinuclear autoantibodies, ANAs, are important not only for the diagnosis of systemic lupus erythematosus, SLE, but also they may be associated with certain clinical features of SLE. 11. Previous studies proved some of these associations, such as the association of anti-dsDNA antibodies with lupus nephritis, 12, 13, anti-SSA and anti-SSB antibodies with Zika symptoms, 12, 14, and anti-RNP antibodies with Raynaud's phenomenon, 12, 13, 15. More associations have been described, but different studies yield conflicting results. 11. The multiplicity of ANAs made it difficult to associate each individual antibody with different manifestations of SLE. Many authors suggested that autoantibody profiles might be a valued alternative to individual autoantibodies. 11, 14. This study aimed to evaluate the relationship between different ANAs detected by ANA immunoassay and different clinical and laboratory characteristics of SLE patients in Upper Egypt. Patients and methods. Study design, descriptive cross-sectional study. Patients. The study included cases diagnosed as SLE according to the 2019 ACR/Schiller classification criteria. 10. Cases were recruited from the outpatient clinic and inpatient part of the Department of Rheumatology, Sohag University, in the period from January 1, 2020 to June 30, 2020. A total of 196 cases were included in the study. Methods. All of the cases were subjected to complete history taking, full general examination, and examination of different organ systems according to the symptomatology and signs of the patients. Investigations. 10 milliliters of venous blood were withdrawn from each subject under aseptic conditions and immediately delivered into vacutainer tubes. Serum was separated using the standard protocol of each laboratory test. The patients were instructed to collect a spot midstream urine sample in a clean, sterile container for the determination of proteinuria. The following investigations were performed. Complete blood count, CBC, was done by CEII, DYN 3700, Abbott Laboratories, Diagnostic Division, Illinois, USA. Spot urine protein/creatinine ratio, up/C ratio, both urinary protein and creatinine concentrations were measured by turbidimetric assay and kinetic colorimetric Jaffe method, respectively, using Cobas C311 chemistry analyzer system, Roche Diagnostics, GmbH, Mannheim, Germany. Up/C ratio in spot urine samples was calculated by dividing the urinary protein concentration in mg/dl by urine creatinine concentration in mg/dl. Up/C ratio of less than 0.2 mg per milligram was considered within normal limits, whereas a ratio above 3.5 was considered as nephrotic range proteinuria. 16. Complement 3, C3, and complement 4, C4, both C3 and C4 were measured by nephelometric immunoassay by using MISPA-I2, AGAP Diagnostics, GmbH, Nanowerstrasse 54 to 6330, Cham, Switzerland. The serum sample reacts upon specific antibody for either human complement C3 or C4 and causes a change in absorbance, which is directly proportional to the concentration of either C3 or C4 consequently in the sample. The reference range for C3 in adults is 90 to 180 mg/dl, while for C4 in adults is 9 to 36 mg/dl. Antinuclear antibody, ANA, by indirect immunofluorescence assay, IIF, on Hep2 cell, approximately 20 to 30 L of diluted serum 1/40th in phosphate buffered saline, PBS, was overlaid onto fixed Hep2 cell, Anafluor, Diasorin, Stillwater, Minnesota, 55082-0285, USA, for 30 minutes at room temperature in a covered moist chamber. Slides were rinsed carefully with PBS, then slides were placed into a Copland jar filled with PBS for about 10 minutes and were agitated gently at time intervals and before removal. Then, slides were removed from the wash buffer and the excess PBS was drained and the excess PBS was blotted from around the wells using a blotting strip. Approximately 20 to 30 L of anti-human immunoglobulin conjugated with fluorescein isothiocyanate, FITC, was dispensed to each well and incubated for an additional 30 minutes protected from excessive light. After washing with PBS as before, a small drop of mounting media was applied to each well and then a cover slip was placed gently over the slide, and the slides were read using a fluorescence microscope at 40x power. Positive and negative controls were run with each test daily. A serum was considered positive if the nuclei of the cells fluoresce with greater or equal intensity than the endpoint reference control well, and there is a discernible pattern of fluorescence. Any positive patient specimen should be confirmed by repeating the test with twofold dilutions of serum. The endpoint titer is the serial dilution, which best approximates the fluorescent intensity of the endpoint reference control reaction. All positive ANA patterns should be titered to endpoint dilution to detect possible mixed antinuclear reactions that may not be apparent when interpreting a single screening dilution. ANA.immunoassay, a commercially available immunoassay, was performed by using Blue Diver Quantrix ANA19 IgG kit, code ANA19Q24, for Blue Diver instrument, BDI, both DTEC, Belgium, intended for the detection in human sera of IgG autoantibodies against nucleosome, dsDNA, histones, SM, RNP, 68kd/AC, SM/RNP, SSA/Rho60kd, SSA/Rho52kd, SSB, SCL70, RNA, polymerase 3, CU, PMSCL100, Me2, Jo1, CENPA/B, PCNA, ribosome P0, and DFS70 antigens. More information on the source/type of antigens is available via company website http://www.d-tech.be. The test principle is based on a classical enzyme immunoassay, EIA. The test strip was composed of a nitrocellulose membrane fixed on special plastic support on which the antigens had been coated a microdot-shaped format. All the antigens and controls were coded in triplicate spotting. During the automated test process, the BDI consecutively incubates the strips in the wells of ready-to-use reagent cartridges. The strips were first incubated with diluted patient sera. On washing, human antibodies, if present, bind to the corresponding specific antigens dotted on the membrane and unbound or excess antibodies are removed. Upon subsequent incubation into alkaline phosphatase, conjugated goat antibodies against human IgG, the enzyme conjugate binds to the antigen-antibody complexes. After removal of the excess conjugate by washing, the strips were finally incubated into a substrate solution. If enzyme activity was present, it would result in the development of purple dots. The intensity of the coloration was directly proportional to the amount of antibody present in the sample. All the measured results were fully quantitative in comparison to a 6-point built-in calibration curve, including blank control. Different types of controls, sample, conjugate, and substrate, were also coded on the strip, and their presence validates the whole procedure of the test. For optimum precision, all dots were coded in a triplicate microdot format, allowing calculation of a mean value and a confidence interval for each parameter, antigens, calibration curve, and controls. Dried strips were visually inspected for staining and imaged using a PhotoSmart C4480 scanner, Hewlett-Packard. The evaluation of the results was performed via the Dr. DOT software. Each strip contains an integrated 6-point standard calibration curve with the values 0, blank, 6, 12, 25, 50, and 100 U/ml. The Dr. DOT software measured the mean color intensity of each antigen triplicate, and the corresponding quantitative value was calculated from the calibration curve and refers to the preset cutoff value to evaluate the result. In the Blue Diver Quantrix ANA19 IgG, the manufacturer's recommended cutoff value is 6 U/ml for all antigens. Low titers of autoantibodies may occur in healthy patients. For this reason, low positive results comprised between 6 to 12 U/ml, although valid, should be considered equivocal. A sample was considered positive for a specific antibody if the value of the corresponding antigen was higher than 12 U/ml. Detection of anticardiolipin IgG/IgM in serum. Both of anticardiolipin IgG and IgM were measured in serum samples using an enzyme-linked immunosorbent assay, ELISA, KIT, Orgentech Diagnostica, GmbH Karl Zeiss Strasse 49-51, 55129, Mainz, Germany, catalog, #ORG515, for anticardiolipin IgG/IgM, according to the manufacturer instructions. Patient samples were diluted at 1:100 before the assay. 10 ml of each sample was added to 990 ml of pre-diluted sample buffer in a polystyrene tube and mixed well. Calibrators and controls are ready to use and need not be diluted. 100 ml of calibrators, controls, and pre-diluted patient samples were pipetted into the wells and incubated for 30 minutes at room temperature. Then, the contents of the microwells were discarded and washed 3 times by previously prepared wash solution. 100 ml of horseradish peroxidase, HRP, conjugated anti-human antibodies either for anticardiolipin IgG or IgM was added to each well. Then, the plate was incubated for 15 minutes at room temperature. The contents of the microwells were discarded and washed 3 times by wash solution. 100 ml of TMB substrate solution was added to each well and incubated for 15 minutes at room temperature. An enzyme substrate in the presence of HRP was catalyzed to form a blue color that changed to yellow color after the reaction was stopped by addition of an acid-stop solution. The absorbance OD was measured at 450 nanometers using Thermo Fisher Scientific Multiscan EX microplate reader, Thermo Fisher Scientific OI, FI01621 Vanta, Finland. The anticardiolipin IgG or IgM concentration of samples was determined by comparing the OD of the samples to a standard curve. The normal cutoff of healthy persons was less than 10 GPLU/ml for anticardiolipin IgG and less than 7 mPLU/ml anticardiolipin IgM. Detection of anti-beta-2 glycoprotein IgG/IgM in serum. Both of anti-beta-2 glycoprotein IgG and IgM were measured in serum samples using an enzyme-linked immunosorbent assay, ELISA, KID, Orgentech Diagnostica, GmbH, Karl Zeiss Strasse 49 to 51, 55129, Mainz, Germany, catalog, #ORG521, for anti-beta-2 glycoprotein IgG/IgM, according to the manufacturer instructions. Patient samples were diluted at 1:100 before the assay. 10 μl of each sample was added to 990 μl of pre-diluted sample buffer in a polystyrene tube and mixed well. Both calibrators and controls were ready to use and did not need dilution. 100 μl of calibrators, controls, and pre-diluted patient samples were pipetted into the wells and incubated for 30 minutes at room temperature. Then, the contents of the microwells were discarded and washed 3 times by previously prepared wash solution. 100 μl of horseradish peroxidase, HRP, conjugated anti-human antibodies either for anti-beta-2 glycoprotein IgG or IgM was added to each well. Then, the plate was incubated for 15 minutes at room temperature. The contents of the microwells were discarded and washed 3 times by wash solution. 100 μl of TMB substrate solution was added to each well and incubated for 15 minutes at room temperature. An enzyme substrate in the presence of HRP was catalyzed to form a blue color that changed to yellow color after the reaction was stopped by addition of an acid-stop solution. The absorbance OD was measured at 450 nanometers using Thermo Fisher Scientific Multiscan EX microplate reader, Thermo Fisher Scientific OI, FI01621 Vanta, Finland. The anti-beta-2 glycoprotein IgG or IgM concentration of samples was determined by comparing the OD of the samples to a standard curve. The normal cutoff of healthy persons was less than 5 U/ml. The borderline result ranged from 5 to 8 U/ml, and the positive result was more than 8 U/ml for either anti-beta-2 glycoprotein IgG or IgM. Lupus anticoagulants, LA. Lupus anticoagulants, LA, was measured by DVV test reagent, REF, 810, Biomedica Diagnostics, 94, Wentworth Road, P.O. Box 1030, Windsor, NS Canada, B0N2T0, which is a dilute Russell's Viper venom time, DRVVT, test intended for the determination of LA in human plasma, using thrombostat semi-automated coagulation analyzer, Bank Electronic GmbH and Company. Hans Bachler-Ring, 27, 22851, Norderstedt, Germany. The reference range for lupus anticoagulants, LA, was 29 to 51 seconds. Statistical analysis. Statistical Package for Social Sciences, IBM SPSS, version 25, IBM Corporation, Chicago, USA, August 2017, was used for statistical data analysis. Data were expressed as mean, standard deviation, SD, number, and percentage. Mean and standard deviation were used as a descriptive value for quantitative data. Pearson chi-square test was used to compare percentages of qualitative variables, and Fisher's exact test was used instead of non-parametric data. For all these tests, a p-value less than 0.05 was considered significant. Sensitivity statistics were done for different individual ANA antibodies included in the ANA.immunoassay, taking immunofluorescence ANA as the gold standard test. The sensitivity statistics were calculated using true positive, cases with positive ANAIF and positive individual ANA. True negative, cases with negative ANAIF and negative individual ANA. False positive, cases with positive individual ANA, but negative for ANAIF. False negative, cases with positive ANAIF, but negative for the individual ANA. Sensitivity equals true positive / true positive plus false negative. Specificity equals true negative / true negative plus false positive. Positive predictive value equals true positive / true positive plus false positive. Negative predictive value equals true negative / true negative plus false negative. Accuracy equals sensitivity plus specificity / 2. Results. The present study included 196 cases, 17 males, 8.7%, and 179 females, 91.3%. The mean age of the study group was 34.27 plus or minus 10.94 years. The most common clinical manifestation was fever, seen in 68.9%, followed by arthralgia, 57.7%, then acute cutaneous lupus, 51.5%, alopecia, 49.5%, proteinuria, 43.9%, arthritis, 43.4%, and oral ulcers, 42.3%. Table 1, Figures 1, 2. Regarding investigations, leukopenia was found in 35.2% of the cases, thrombocytopenia in 28.1%, and hemolytic anemia in 18.9%. Renal involvement was present in 86 cases, 43.9%, with biopsy-proved LN class 3 or 4 in 36.7% of the cases, class 2 and V in 7.1% of them. Complement was consumed in less than 15% of the cases, and APL antibodies in only 4 cases, 2%. Table 1, Figure 3. Regarding ANA, the ANAIF was positive in the vast majority of cases, 95.9%, with a wide variation of titers from 1/40th up to 1/10240. The most common pattern seen was speckled, seen alone or in association with other patterns in 52.5% of the cases, followed by homogeneous pattern, 43.8% of the cases. Other patterns were seen in a minority of the cases. The ANA.immunoassay showed that the most common ANA found was anti-Rho60, 48.5%, followed by anti-dsDNA, 45.4%, then anti-Rho52, 36.7%, anti-nucleosome, 34.7%, anti-SM/RNP, 23%, anti-RNP, 20.9%, anti-histone, 19.4%, anti-SM, 16.8%, anti-LA, 15.8%, anti-DFS 70, 12.2%, anti-ribosome, 10.2%, anti-SCL 100, 9.2%, anti-PCNA, 8.2%, anti-CU, 6.6%, anti-CENP, 3.6%, anti-SCL 70, 3.1%, anti-RNA polymerase 3, and anti-Jo1, 0.5%. None of the cases showed anti-Me2 antibody, Table 2, Figures 4, 5. Table 3, A and B, shows the sensitivity statistics of different ANA.immunoassay antibodies, taking into consideration the ANAIF as a gold standard. Tables 4 to 10 shows the association between different ANA antibodies included in the ANA.immunoassay and different systemic and laboratory findings of the study population. Table 4 showed the association between ANA.immunoassay and mucocutaneous manifestations and fever. Table 5 shows the association with musculoskeletal manifestations. Table 6 shows the association with neuropsychiatric manifestations. Table 7 showed the association with pleuropericardial manifestations. Table 8 shows the association with CBC. Table 9 shows the association with renal involvement, and finally, Table 10 shows the association with complement consumption. Discussion. ANAs consist of various types of autoantibodies characterized by different antigen specificities. 17. First, it was suggested that the titer and pattern may give a clue regarding the nature of antigenic specificity, and hence the pathogenesis of ANA among different SLE patients. 18. Certain patterns of fluorescence are associated with certain nuclear antigens and specific disease. Patterns of staining can provide a clue to the class of nuclear antigen involved, yet they may be dependent upon the type of substrate used, and to a certain extent, the experience of the technician. Reliance on ANA patterns has largely been replaced by identification of specific antinuclear antibodies through the ANA immunoassay. 17. Our study aimed to evaluate the relationship between different ANAs detected by ANA immunoassay and different clinical and laboratory characteristics of SLE patients in Upper Egypt. Regarding fever and mucocutaneous manifestations, we found a significant association between anti-nucleosome and oral ulcers, between anti-dsDNA and each of fever, oral ulcers, and acute cutaneous lupus, between anti-SM and each of oral ulcers and subacute cutaneous lupus, between anti-Q and fever, between each of anti-CNP and anti-ribosome and discoid cutaneous lupus. Interestingly, we found a negative and significant relation between fever and anti-DFS70, and also between anti-Ro52 and alopecia, Table 4. Our results somewhat agree with that of Mahmoudi et al. 19, who stated that anti-dsDNA was significantly associated with cutaneous manifestations of SLE. Regarding arthritis, the only significant association found was the association with anti-PCNA antibodies, Table 5. This was not agreed with the studies of Hefny et al. 20, and Mahmoudi et al. 19, who found a significant association between anti-dsDNA and arthritis. Regarding neuropsychiatric lupus, delirium was significantly associated with anti-Q, anti-CNP, and anti-ribosome. Seizures were associated significantly with anti-CNP. Psychosis was significantly associated positively with anti-SM, anti-RNP, and anti-SCL70, and negatively with anti-Ro52, Table 6. According to Hefny et al. 20, seizures were associated with anti-SM, anti-RNP, and anti-ribosomal P only. Regarding pleuropericardial manifestations, pleural effusion was significantly associated with anti-Ro52. Pericardial effusion was significantly associated with anti-dsDNA, antihistone, and anti-SCL100 antibodies, Table 7. Regarding hematological manifestations, hemolytic anemia was significantly associated with anti-Q, and thrombocytopenia was associated with both anti-Q and anti-SM. Leukopenia was not associated significantly with any of the 19 antibodies, Table 8. This was not agreed by the study of Mahmoudi et al. 19, where hematological manifestations were significantly associated with positive anti-dsDNA. Regarding lupus nephritis, proteinuria was positively associated with anti-dsDNA, antihistone, and anti-SM, and negatively associated with anti-Ro52 and anti-La antibodies. Class 3 and 4 LN were positively associated with anti-dsDNA. On the other hand, classes 2 and B of LN were not associated with any of the 19 autoantibodies studied in this study, Table 9. This was somewhat agreed by the study of Hefny et al. 20, who stated a significant correlation between LN and each of anti-dsDNA, anti-Ro52, anti-Ro60, and anti-RNP. According to Ahmed et al. 21, anti-dsDNA was associated with a higher risk for LN, an association which was opposite to the negative association between anti-Jo1 and anti-PCNA positivity and LN. Although anti-nucleosome antibody was not associated with the presence of LN, it was found to be significantly associated with the more aggressive classes of LN, class 3 and 4. Regarding complement, both C3 and C4 were associated with anti-nucleosome, anti-dsDNA, antihistone, anti-SM, Table 10. According to Hefny et al. 20, the presence of anti-dsDNA was significantly associated with LN, chorea, photosensitivity, and arthritis. LN was also associated with anti-Ro52, anti-Ro60, and anti-RNP. Seizures were associated with positive anti-SM, anti-RNP, and anti-ribosomal P. They also found that Raynaud's phenomenon was associated with anti-RNP, anti-Ro52, anti-Ro60, and antihistone antibodies. In the study done by Mahmoudi et al. 19. They found that anti-dsDNA was mostly associated with cutaneous lupus, musculoskeletal manifestations, and hematological features of lupus. Antinucleosome was mostly associated with LN and thrombotic disorders. Anti-Rho52 was associated with neurological lupus and abortion. Finally, they found that anti-RNP was associated with both ocular manifestations and oral ulcers. Conclusion. The ANA.immunoassay is essential for the diagnosis, prediction, and assessment of internal organ involvement and for follow-up and prognosis of SLE cases. Declarations and conflict of interests. Ethics approval. The research was approved for application from the local ethical committee of Sohag University Hospital. Medical and personal information were kept confidential. The study was performed in accordance with the principles of the Declaration of Helsinki. Consent to participate. All included cases signed an informed written consent after detailed explanation of the research nature. Availability of data and material. Data of the current study are available with the corresponding author, but patients' personal data would not be given to a third party. Competing interests. The authors declare that there are no competing interests. Funding. The authors did not receive any funding from any governmental or private sources. All authors have read and approved the manuscript. References. 1. Old K. Richardson, B. Pathogenesis of Lupus. Arthritis Room. 2002, 47, 343 to 345. 2. Latif A. Petrie M. Unmet Medical Needs in Systemic Lupus Erythematosus. Arthritis Residential Der. 2012, 14 Supple 4, S4. 3. Rahman A. Eisenberg D.A. Systemic Lupus Erythematosus. N. England J. Med. 2008, 358, 929 to 939. 4. Ghosh P. Dwivedi S. Naik S. Agarwal V. Barma A. Agarwal A. et al. Antinuclear antibodies by indirect immunofluorescence. Optimum screening dilution for diagnosis of systemic lupus erythematosus. Indian J. Med. Res. 2007, 126, 134 to 38. 5. Asser K. Walker J. A. Leaf P. D. Barland P. Bank N. Triad of glomerulonephritis, antinuclear antibodies, and positive skin immunofluorescence. Variant of systemic lupus erythematosus. AMJ Med. 1983, 74, 183 to 89. 6. Wierzchowiecki M. Detection of antinuclear antibodies in patients with systemic lupus erythematosus by the indirect immunofluorescence test. Pol Arch Med 1. 1973, 50, 11, 1227 to 1235. 7. Tan EM, Cohen AS, Fries JF, Massey at, McShane DJ, Rothfield NF, et al. The 1982 revised criteria for the classification of systemic lupus erythematosus. Arthritis Room. 1982, 25, 11, 1271 to 1277. 8. Hochberg MC, updating the American College of Rheumatology revised criteria for the classification of systemic lupus erythematosus. Arthritis Room. 1997, 40, 9, 1725. 9. Petrie M. Orby AM, Alarcon GS, Gordon C., Merrill JT, Fortin PR, et al. Derivation and validation of the Systemic Lupus International Collaborating Clinics classification criteria for systemic lupus erythematosus. Arthritis Room. 2012, 64, 8, 2677 to 2686. 10. Ehringer M. Kostenbader K. Dake D. Brinks R. Mosca M. Ramsey Goldman R. et al. 2019 European League Against Rheumatism / American College of Rheumatology classification criteria for systemic lupus erythematosus. And Room Dis 2019, 78, 9, 1151 to 1159. 11. Hoffman IE, Pien I, Mejias L., Huizinga T.W., Sevicor L., Eisenberg D., et al. Specific antinuclear antibodies are associated with clinical features in systemic lupus erythematosus. And Room Dis, 2004, 63, 9 1155 to 1158. 12. Cervera R., Kamashta M.A., Font J., Sebastiani G.D., Gil A., Lavilla P., et al. Systemic lupus erythematosus, clinical and immunologic patterns of disease expression in a cohort of 1,000 patients. The European Working Party on Systemic Lupus Erythematosus. Medicine, Baltimore. 1993, 72, 113 to 124. 13. Sulceep G., Morca K. Diagnostic and prognostic significance of different antinuclear antibodies in more than 1,000 consecutive Albanian patients with rheumatic diseases. Clin Exp Rheumatol. 1992, 10, 3, 255 to 261. 14. Thompson D., Juby A., Davis P. The clinical significance of autoantibody profiles in patients with systemic lupus erythematosus. Lupus. 1993, 2, 1, 15 to 19. 15. Terborghi J., Groen H., Horst G., Limburg PC, Wouda AA, Collenberg CG, editors. Clinical associations of antiribonucleoprotein antibodies in patients with systemic lupus erythematosus. Seminars in Arthritis and Rheumatism, 1990, Elsevier. 16. Ginsberg J.M., Chong B.S., Matariz R.A., Garella S. Use of single-voided urine samples to estimate quantitative proteinuria. New England Journal of Medicine. 1983, 309, 25, 1543 to 1546. 17. Wijaya C., Baranyu. The role of antinuclear antibody, ANA, profile in diagnosis of systemic lupus erythematosus. ADV Saital Pathal. 2017, 2, 5, 133 to 134. 18. Sotomi, Hernandez Becerril N., Perez-Chini AC, Hernandez Rizo A., Telekdariba J.E., Juarzo Roscoe L.E., et al. Predictive value of antinuclear antibodies in autoimmune diseases, classified by clinical criteria, analytical study in a specialized health institute, 1-year follow-up. Results Immunol. 2015, 5, 13 to 22. 19. Mahmoudi M., Rastin M., Sahabari M., Zamani S., Tabasi N., Autoantibody Profile, Disease Activity, and Organ Involvement in Iranian Systemic Lupus Erythematosus Patients. Rheumatology Research. 2017, 2, 1, 11 to 16. 20. Hefni M.A., Goma N.I., Fabi A., Labib S., Associations between specific antinuclear antibodies, detected by line immunoassay, and clinical features of patients with systemic lupus erythematosus. Egyptian Journal of Medical Microbiology. 2006, 15, 2. 21. Ahmed N., Shijadi M., Abdulrahman H., Taha E. Clinical features and antinuclear antibodies profile among adults with systemic lupus erythematosus and lupus nephritis, a cross-sectional study. Pan-African Medical Journal. 2017, 27, 1. Table 1. Demographic and clinical data of the study group. Item. Value. Sex. Male. 17, 8.7%. Female. 179, 91.3%. Age. Mean plus or minus SD. 34.27 plus or minus 10.94. Median range. 32, 19 to 70. Clinical manifestations. Fever. 135, 68.9%. Alopecia. 97, 49.5%. Oral ulcers. 83, 42.3%. Subacute cutaneous lupus. 16, 8.2%. Discoid lupus, DLE. 10, 5.1%. Acute cutaneous lupus. 101, 51.5%. Arthritis. 85, 43.4%. Arthralgia. 113, 57.7%. Delirium. 1, 0.5%. Psychosis. 9, 4.6%. Seizure. 4, 2%. Pleural effusion. 24, 12.2%. Pericardial effusion. 13, 6.6%. CBC. Leukopenia. 69, 35.2%. Thrombocytopenia. 55, 28.1%. Hemolytic anemia. 37, 18.9%. Urine analysis. Proteinuria. 86, 43.9%. Renal biopsy. Class 3/4. 72, 36.7%. Class 2/V. 14, 7.1%. APL antibodies. 4, 2%. Complement. C3 consumption. 27, 13.8%. C4 consumption. 26, 13.3%. Table 2. Antinuclear antibody profile. Item. Value. ANA by F. Positive. 188, 95.9%. Negative. 8, 4.1%. ANA titer. 1/40th. 29, 14.8%. 1 of 80. 29, 14.8%. 1/160. 16, 8.2%. 1/320. 25, 12.8%. 1/640. 35, 17.9%. 1/1280. 15, 7.7%. 1/2560. 17, 8.7%. 1/5120. 21, 10.7%. 1/10240. 1, 0.5%. ANA pattern. Homogeneous. 80, 40.8%. Speckled. 96, 49%. Homogeneous and speckled. 5, 2.6%. Speckled and cytoplasmic ribosomal. 1, 0.5%. Peripheral. 1, 0.5%. Speckled and rim. 1, 0.5%. Nucleolar. 3, 1.5%. Homogeneous and nucleolar. 1, 0.5%. ANA. Immunoassay. Antinucleosome. 68, 34.7%. Anti-double-stranded DNA. 89, 45.4%. Antihistone. 38, 19.4%. Anti-Smith, SM. 33, 16.8%. Anti-RNP, 68 KD/AC. 41, 20.9%. Anti-SM/RNP. 45, 23%. Anti-SSA/Rho60. 95, 48.5%. Anti-SSA/Rho52. 72, 36.7%. Anti-SSB/LA. 31, 15.8%. Anti-SCL70. 6, 3.1%. Anti-RNA polymerase 3. 1, 0.5%. Anti-Q, 13, 6.6%. Anti-PMSCL 100, 18, 9.2%. Anti-Me Too, 0. Anti-Joe 1, 0.5%. Anti-CNPA/B, 7, 3.6%. Anti-PCNA, 16, 8.2%. Anti-ribosome PO, 20, 10.2%. Anti-DFS70, 24, 12.2%. Table 3. Sensitivity statistics of ANA.immunoassay. ANA.immunoassay. True positive. False positive. True negative. False negative. Antinucleosome. 64. 4. 13. 115. Anti-double-stranded DNA. 82. 7. 10. 97. Antihistone. 38. 0. 17. 141. Anti-Smith, SM. 33. 0. 17. 146. Anti-RNP, 68 KD/AC. 41. 0. 17. 138. Anti-SM/RNP. 43. 2. 15. 136. Anti-SSA/Rho60. 92. 3. 14. 87. Anti-SSA/Rho52. 69. 3. 14. 110. Anti-SSB/Law. 30. 1. 16. 149. Anti-SCL70. 5. 1. 16. 174. Anti-RNA polymerase 3. 1. 0. 17. 178. Anti-Q. 13. 0. 17. 166. Anti-PMSCL 100. 17. 1. 16. 162. Anti-Me Too. 0. 0. 17. 179. Anti-Joe 1. 1. 0. 17. 178. Anti-CNPA/B. 7. 0. 17. 172. Anti-PCNA. 13. 3. 14. 166. Anti-ribosome PO. 20. 0. 17. 159. Anti-DFS70. 20. 4. 13. 159. ANA.immunoassay. Sensitivity. Specificity. PPV. NPV. Accuracy. Antinucleosome. 35.75%. 76.47%. 94.12%. 10.16%. 56.11%. Anti-double-stranded DNA. 45.81%. 58.82%. 92.13%. 9.35%. 52.32%. Antihistone, 21.23%. 100%. 100%. 10.76%. 60.61%. Anti-Smith, SM, 18.44%. 100%. 100%. 10.43%. 59.22%. Anti-RNP, 68 kD/AC, 22.91%. 100%. 100%. 10.97%. 61.45%. Anti-SM/RNP, 24.02%. 88.24%. 95.56%. 9.93%. 56.13%. Anti-SSA/Rho60, 51.4%. 82.35%. 96.84%. 13.86%. 66.87%. Anti-SSA/Rho52, 38.55%. 82.35%. 95.83%. 11.29%. 60.45%. Anti-SSB/Law, 16.76%. 94.12%. 96.77%. 9.7%. 55.44%. Anti-SCL70, 2.79%. 94.12%. 83.33%. 8.42%. 48.46%. Anti-RNA polymerase 3, 0.56%. 100%. 100%. 8.72%. 50.28%. Anti-Q, 7.26%. 100%. 100%. 9.29%. 53.63%. Anti-PMSCL100, 9.5%. 94.12%. 94.44%. 8.99%. 51.81%. Anti-Me2, 0. 100%. 8.67%. 50%. Anti-Jo1, 0.56%. 100%. 100%. 8.72%. 50.28%. Anti-CNPA/B, 3.91%. 100%. 100%. 8.99%. 51.96%. Anti-PCNA, 7.26%. 82.35%. 81.25%. 7.78%. 44.81%. Anti-ribosome PO, 11.17%. 100%. 100%. 9.66%. 55.59%. Anti-DFS70, 11.17%. 76.47%. 83.33%. 7.56%. 43.82%. PPV, positive predictive value, NPV, negative predictive value. Table 4. Constitutional and mucocutaneous symptoms in relation to ANA. Immunoassay. Fever, alopecia, oral ulcers, SLE, DCL, ACL, antinucleosome, 51, 75%, 36, 52.9%, 42, 61.8%, asterisk, 8, 11.8%, 5, 7.4%, 39, 57.4%, anti-double-stranded DNA, 68, 76.4%, asterisk, 50, 56.2%, 50, 56.2%, asterisk, 9, 10.1%, 7, 7.9%, 56, 62.9%, asterisk, antihistone, 32, 84.2%, asterisk, 17, 44.7%, 19, 50%, 5, 13.2%, 2, 5.3%, 16, 42.1%, anti-Smith, SM, 27, 81.8%, 18, 54.5%, 20, 60.6%, asterisk, 6, 18.2%, asterisk, 2, 6.1%, 20, 60.6%, anti-RNP, 68 kd/AC, 30, 73.2%, 22, 53.7%, 21, 51.2%, 5, 12.2%, 1, 2.4%, 21, 51.2%, anti-SM/RNP, 34, 75.6%, 21, 46.7%, 22, 48.9%, 6, 13.3%, 3, 6.7%, 26, 57.8%, anti-SSA/Rho 60, 67, 70.5%, 44, 46.3%, 35, 36.8%, 8, 8.4%, 4, 4.2%, 47, 49.5%, anti-SSA/Rho 52, 52, 72.2%, 29, 40.3%, caret, 24, 33.3%, 6, 8.3%, 1, 1.4%, 32, 44.4%, anti-SSB/law, 23, 74.2%, 15, 48.4%, 9, 29%, 3, 9.7%, 1, 3.2%, 12, 38.7%, anti-SCL 70, 4, 66.7%, 1, 16.7%, 2, 33.3%, 0, 1, 16.7%, 3, 50%, anti-RNA polymerase 3, 0, 1, 100%, 0, 0, 0, 1, 100%, anti-Q, 12, 92.3%, asterisk, 7, 53.8%, 6, 46.2%, 2, 15.4%, 2, 15.4%, 6, 46.2%, anti-PMSCL 100, 11, 61.1%, 6, 33.3%, 7, 38.9%, 1, 5.6%, 0, 11, 61.1%, Anti-Me Too. 0. 0. 0. 0. 0. 0. Anti-Joe 1. 0. 0. 0. 0. 0. 0. Anti-CNPA/B. 6. 85.7%. 4. 57.1%. 3. 42.9%. 1. 14.3%. 2. 28.6%. Asterisk. 4. 57.1%. Anti-PCNA. 10. 62.5%. 10. 62.5%. 4. 25%. 0. 0. 8. 50%. Anti-ribosome PO. 16. 80%. 12. 60%. 8. 40%. 3. 15%. 3. 15%. Asterisk. 12. 60%. Anti-DFS 70. 11. 45.8. Carat. 13. 54.2%. 9. 37.5%. 2. 8.3%. 1. 4.2%. 10. 41.7%. Asterisk antibody significantly associated with higher incidence. Carat antibody significantly associated with lower incidence. SCSLE, subacute cutaneous systemic lupus erythematosus. DLE, discoid lupus erythematosus. ACL, acute cutaneous lupus. Table 5. Musculoskeletal manifestations in relation to ANA. Immunoassay. Arthritis. Arthralgia. Antinucleosome. 44, 64.7%. 31, 45.6%. Anti-double-stranded DNA. 53, 59.6%. 41, 46.1%. Antihistone. 21, 55.3%. 17, 44.7%. Anti-Smith, SM. 18, 54.5%. 18, 54.5%. Anti-RNP, 68 kd/AC. 27, 65.9%. 15, 36.6%. Anti-SM/RNP. 30, 66.7%. 16, 35.6%. Anti-SSA/Rho60. 50, 52.6%. 43, 45.3%. Anti-SSA/Rho52. 39, 54.2%. 27, 37.5%. Anti-SSB/Law. 14, 45.2%. 14, 45.2%. Anti-SCL70. 4, 66.7%. 4, 66.7%. Anti-RNA polymerase 3. 1, 100%. 0. Anti-Q. 8, 61.5%. 5, 38.5%. Anti-PMSCL 100. 10, 55.6%. 8, 44.4%. Anti-Me Too. 0. 0. Anti-Joe 1. 1, 100%. 0. Anti-CNPA/B. 5, 71.4%. 4, 57.1%. Anti-PCNA. 13, 81.3%. Asterisk. 4, 25%. Anti-ribosome PO. 11, 55%. 12, 60%. Anti-DFS 70. 13, 54.2%. 9, 37.5%. Asterisk antibody significantly associated with higher incidence. Carried antibody significantly associated with lower incidence. Table 6. Neuropsychiatric manifestations in relation to ANA. Immunoassay. Delirium. Psychosis. Seizures. Antinucleosome. 1, 1.5%. 4, 5.9%. 1, 1.5%. Anti-double-stranded DNA. 1, 1.1%. 6, 6.7%. 2, 2.2%. Antihistone. 0. 3, 7.9%. 1, 2.6%. Anti-Smith, SM. 1, 3%. 5, 15.2%, asterisk. 2, 6.1%. Anti-RNP, 68 kD/AC. 1, 2.4%. 5, 12.2%, asterisk. 2, 4.9%. Anti-SM/RNP. 1, 2.2%. 4, 8.9%. 2, 4.4%. Anti-SSA/Rho60. 0. 2, 2.1%. 0. Anti-SSA/Rho52. 0. 0, 0%, caret. 0. Anti-SSB/Law. 0. 0. 0. Anti-SCL70. 0. 2, 33.3%, asterisk. 0. Anti-RNA polymerase 3. 0. 0. 0. Anti-Q. 1, 7.7%, asterisk. 1, 7.7%. 1, 7.7%. Anti-PMSCL 100. 0. 1, 5.6%. 0. Anti-Me2. 0. 0. 0. Anti-Jo1. 0. 0. 0. Anti-CNPA/B. 1, 14.3%, asterisk. 1, 14.3%. 1, 14.3%, asterisk. Anti-PCNA. 0. 0. 0. Anti-ribosome PO. 1, 5%, asterisk. 2, 10%. 1, 5%. Anti-DFS 70. 0. 1, 4.2%. 1, 4.2%. Asterisk antibody significantly associated with higher incidence. Carried antibody significantly associated with lower incidence. Table 7. Pleuropericardial manifestations in relation to ANA. Immunoassay. Pleural effusion. Pericardial effusion. Antinucleosome. 10, 14.7%. 7, 10.3%. Anti-double-stranded DNA. 15, 16.9%. 10, 11.2%, asterisk. Antihistone. 8, 21.1%. 6, 15.8%, asterisk. Anti-Smith, SM. 3, 9.1%. 3, 9.1%. Anti-RNP, 68 kD/AC. 4, 9.8%. 5, 12.2%. Anti-SM/RNP. 5, 11.1%. 4, 8.9%. Anti-SSA/Row 60. 11, 11.6%. 5, 5.3%. Anti-SSA/Row 52. 13, 18.1%, asterisk. 4, 5.6%. Anti-SSB/Law. 3, 9.7%. 1, 3.2%. Anti-SCL 70. 1, 16.7%. 1, 16.7%. Anti-RNA polymerase 3. 0. 0. Anti-Q. 1, 7.7%. 1, 7.7%. Anti-PMSCL 100. 3, 16.7%. 4, 22.2%, asterisk. Anti-Me2. 0. 0. Anti-Jo 1. 0. 0. Anti-CNPA/B. 0. 1, 14.3%. Anti-PCNA. 0. 1, 6.3%. Anti-ribosome PO. 2, 10%. 2, 10%. Anti-DFS 70. 3, 12.5%. 2, 8.3%. Asterisk antibody significantly associated with higher incidence. Carried antibody significantly associated with lower incidence. Table 8. CBC in relation to ANA. Immunoassay. Leukopenia. Thrombocytopenia. Hemolytic anemia. Antinucleosome. 23, 33.8%. 21, 30.9%. 17, 25%. Anti-double-stranded DNA. 34, 38.2%. 29, 32.6%. 21, 23.6%. Antihistone. 11, 28.9%. 14, 36.8%. 9, 23.7%. Anti-Smith, SM. 13, 39.4%. 15, 45.5%, asterisk. 7, 21.2%. Anti-RNP, 68 kD/AC. 17, 41.5%. 13, 31.7%. 8, 19.5%. Anti-SM/RNP. 16, 35.6%. 14, 31.1%. 9, 20%. Anti-SSA/Row 60. 36, 37.9%. 24, 25.3%. 14, 14.7%. Anti-SSA/Row 52. 31, 43.1%. 17, 23.6%. 10, 13.9%. Anti-SSB/Law. 12, 38.7%. 7, 22.6%. 4, 12.9%. Anti-SCL 70. 1, 16.7%. 2, 33.3%. 1, 16.7%. Anti-RNA polymerase 3. 0. 0. 0. Anti-Q. 4, 30.8%. 7, 53.8%, asterisk. 6, 46.2%, asterisk. Anti-PMSCL 100. 3, 16.7%. 6, 33.3%. 2, 11.1%. Anti-Me2. 0, 0, 0. Anti-Jo 1, 100%, 100%, 0. Anti-CNPA/B, 1, 14.3%, 3, 42.9%, 1, 14.3%. Anti-PCNA, 5, 31.3%, 5, 31.3%, 4, 25%. Anti-ribosome PO, 8, 40%, 6, 30%, 5, 25%. Anti-DFS 70, 9, 37.5%, 7, 29.2%, 4, 16.7%. Asterisk antibody significantly associated with higher incidence. Carried antibody significantly associated with lower incidence. Table 9. Renal involvement in relation to ANA. Immunoassay. Proteinuria. Class 3/4 LN. Class 2/V LN. Antinucleosome. 33, 48.5%. 27, 39.7%. 6, 8.8%. Anti-double-stranded DNA. 46, 51.7%, asterisk. 40, 44.9%, asterisk. 6, 6.7%. Antihistone. 24, 63.2%, asterisk. 19, 50%. 5, 13.2%. Anti-Smith, SM. 21, 63.6%, asterisk. 17, 51.5%. 4, 12.1%. Anti-RNP, 68 kD/AC. 22, 53.7%. 20, 48.8%. 2, 4.9%. Anti-SM/RNP. 22, 48.9%. 20, 44.4%. 2, 4.4%. Anti-SSA/Rho60. 35, 36.8%, caret. 31, 32.6%. 4, 4.2%. Anti-SSA/Rho52. 28, 38.9%. 24, 33.3%. 4, 5.6%. Anti-SSB/Law. 8, 25.8%, caret. 7, 22.6%. 1, 3.2%. Anti-SCL70. 2, 33.3%. 2, 33.3%. 0. Anti-RNA polymerase 3. 1, 100%. 1, 100%. 0. Anti-Q. 8, 61.5%. 7, 53.8%. 1, 7.7%. Anti-PMSCL 100. 7, 38.9%. 7, 38.9%. 0. Anti-Me2. 0. 0. 0. Anti-Jo 1. 1, 100%. 1, 100%. 0. Anti-CNPA/B. 3, 42.9%. 3, 42.9%. 0. Anti-PCNA. 8, 50%. 8, 50%. 0. Anti-ribosome PO. 11, 55%. 10, 50%. 1, 5%. Anti-DFS 70. 12, 50%. 11, 45.8%. 1, 4.2%. Asterisk antibody significantly associated with higher incidence. Carried antibody significantly associated with lower incidence. Table 10. Complement in relation to ANA. Immunoassay. C3 consumption. C4 consumption. Antinucleosome. 15, 22.1%, asterisk. 15, 22.1%, asterisk. Anti-double-stranded DNA. 20, 22.5%, asterisk. 20, 22.5%, asterisk. Antihistone. 12, 31.6%, asterisk. 12, 31.6%, asterisk. Anti-Smith, SM. 9, 27.3%, asterisk. 9, 27.3%, asterisk. Anti-RNP, 68 kd/AC. 8, 19.5%. 8, 19.5%. Anti-SM/RNP. 6, 13.3%. 6, 13.3%. Anti-SSA/Rho60. 9, 9.5%. 9, 9.5%. Anti-SSA/Rho52. 6, 8.3%. 6, 8.3%. Anti-SSB/Law. 2, 6.5%. 2, 6.5%. Anti-SCL70. 1, 16.7%. 1, 16.7%. Anti-RNA polymerase 3. 0. 0. Anti-Q. 4, 30.8%. 4, 30.8%. Anti-PMSCL 100. 1, 5.6%. 1, 5.6%. Anti-Me2. 0. 0. Anti-Jo1. 0. 0. Anti-CENPA/B. 2, 28.6%. 2, 28.6%. Anti-PCNA. 1, 6.3%. 0. Anti-ribosome PO. 4, 20%. 4, 20%. Anti-DFS70. 3, 12.5%. 3, 12.5%. Asterisk antibody significantly associated with higher incidence. Carried antibody significantly associated with lower incidence. Figure legend. Figure 1. Age distribution of the study population. Figure 2. Clinical manifestations of the study population. Figure 3. Investigations of the study population. Figure 4. ANA titer done by if. Figure 5. ANA. Immunoassay.